Hi everyone, and welcome to today's webinar. My name is Connie and I'm the social media coordinator for the Canadian Cancer Survivor Network. On behalf of CCSN, I'd like to thank you for attending today's webinar on the importance of cancer rehabilitation presented by Dr. Jennifer Jones. If you're new to one of our webinars, let me take a moment to give you a brief overview of our organization. Excuse me, 1 second. Sorry, we had a technical issue with my presentation. So like I was saying, if you're new to one of our webinars, let me take a moment to give you a brief overview of our organization. The Canadian Cancer Survivor Network, CCSN, is an organization working with cancer patients and survivors to learn about the complexities of our health system, to connect with others, to plan action and act on those plans to promote better care and healthier survivorship. If you'd like to learn more about CCSN, please visit our website at www.survivornet.ca. You'll find lots of information there on us, as well as news, events, and other resources that we think you will find helpful. I have 2 quick announcements before I hand things over to our presenter today. Today, this webinar is being recorded and it will be available tomorrow on YouTube. The video link will be sent to the email you provided when you registered. So you can share this resource or go back and watch it again later if you'd like. At the end of the presentation, we'll have a short Q&A session for those in attendance. We'll be ending our recording beforehand. However, don't feel the need to wait until the end. Please feel free to type questions into the window at the bottom right of your screen so we can have them queued up and ready to go. Okay, about today's webinar, we'd like to welcome Dr. Jennifer Jones. Dr. Jones is the Butterfield Drew Chair in Cancer Survivorship Research and the Director of Cancer Rehabilitation and Survivorship Program at the Princess Margaret Cancer Centre. In addition, she is a senior scientist at the Princess Margaret Research Institute and an associate professor in the Department of Psychiatry, which is primary, and the Dalla Lana School of Public Health cross appointment at the University of Toronto. Now it's my pleasure to pass the floor to Dr. Jones. Dr. Jones? Dr. Jones? I'm waiting for Dr. Jones to...
There we go. I think you had me muted, so.
Oh, I apologize, sorry.
Okay, that's okay. All right, can you see my slide, my first slide?
I can't, my screen is frozen, unfortunately. So this is what I can see.
Oh, okay. Hopefully everybody can see it. So welcome, everybody. Thank you so much for having me today. I really appreciate it, Connie. And it's my, oh, am I sharing my screen? I don't know what's happened. Sorry. There we go. Should see it now. Can you see it? You'd think by now, after a couple of years of COVID, that we'd be good at this technology, but there are all these different platforms, so it makes it a little bit challenging. Anyway, it's my pleasure to talk about cancer rehab today. I'm hoping you can see my screen, and if you can't, Connie, just let me know. I'll just go to the next slide. So yeah, I was asked today to talk a little bit about cancer rehab and why it's important. It's something that's near and dear to my heart, obviously. I've sort of spent all my life in this, my professional life. So what I wanted to do was just provide a nice overview to start with about the needs of cancer survivors, the importance of cancer rehab, where we're sort of at with cancer rehab here in Canada. And then I'm going to talk very briefly about what we offer here at Princess Margaret as sort of a demonstration project and something that we should all be striving for, I think. And then I'm going to spend the last little bit of my talk on a grant that we received a couple of years ago. It's a team grant that we received. And we're running 3 large projects to expand access and reach of cancer rehab in Canada. And the Canadian Cancer Survivors Network is a part of that grant. So I'm just going to provide an overview of those projects and a little bit of an update on how they're going. and then hopefully we'll have a little bit of time at the end for questions. So I have no conflicts of interest to disclose. I just like to start with that. Okay, so just starting with our numbers here, and you're probably all very aware of this, but we now have over 2 million people who have been diagnosed and are living with a personal history of cancer in Canada, and nearly 1 in 2 Canadians is expected to be diagnosed with cancer in their lifetime. And looking forward, because we have an aging population, we're expecting that there's actually going to be a significant increase in the number of people who are diagnosed and living with a personal history of cancer over the next couple decades. But this isn't all bad news. The good news is that what we've seen over the past 2 decades is that the mortality rates for some of the more common cancers have dramatically improved. And this is due to a couple of different factors. So for example, tobacco control, there's less people smoking. We were able to detect cancers quite early now with screening. And we also have better treatments, and that is continuing to improve, especially with the addition of more targeted therapies, immunotherapies, those types of new treatments. So as a result now, the sort of five-year survival estimates are for all cancers combined, which is sort of a fairly not a totally accurate representation, because combining all the cancers, there's quite a large amount of variation, but it is around 63%. But when we look at some of the common cancers like breast and prostate, the 5-year survival rates are closer to 90%. So that's great. And we've seen these mortality rates decrease quite significantly, as I said, over the past couple decades. So when we talk about cancer survivors and cancer survivorship, there are these are 2 different sort of things to think about. So cancer survivors, using a very broad definition, is anybody who is being diagnosed with cancer from the point of diagnosis through to the remainder of their lives. So from the point that you're diagnosed, you would be considered a cancer survivor. When we talk about cancer survivorship or cancer survivorship care, we're typically talking more about at the end of treatment. So when people have sort of finished with their acute treatments, like their chemotherapies, radiation therapies, or the surgery, and now they're in that sort of follow-up surveillance phase, or in some cases, people are have managed chronic or intermittent disease. So more and more people are living with sort of chronic cancer. So that would also be considered a time when they could receive and would benefit from survivorship care. So, sorry, 1 second. I'm just gonna pull up slides. So that it is great news that people are surviving more and people are living longer with cancer. But I think what's really important is that we consider what the cost is of that and develop appropriate services to address the needs of those growing number of cancer survivors. Cancer, unlike other chronic diseases like diabetes or arthritis, has disability associated with it that's due to the disease and the cancer treatments that we give to people as opposed to the disease itself. So, so often what you'll see is somebody's going along their lives, they're working, everything's going well, all of a sudden they get diagnosed with cancer. They could have been feeling perfectly well, there's no disability or impairments at this point, and then they get diagnosed with cancer. And then they undergo a whole combination of treatments, whatever it is that they undergo, and they come out of the cancer system often disabled or dealing with multiple side effects or impairments. And at this phase, we don't really have a lot of services in place to help people like you would in cases like heart disease or diabetes, where they are considered chronic diseases, and so there are a lot more supports in place. So very much our system is sort of set up as an acute care system where people come in, they get their treatment, and they come out, but we're not looking at this phase after treatment and how we can help people to recover. So there are a lot of different challenges that cancer survivors face. We know that almost all of cancer treatments can result in side effects that can impair people's well-being, their functioning, and their overall quality of life. And many of these develop during treatment, and those are called acute side effects, and they end once treatment ends. For example, fatigue. Most people will get fatigue during treatment, but you know, as soon as treatment ends or the next couple months after treatment ends, the fatigue goes away and they start feeling back to themselves. But there are some times where that fatigue or other symptoms persist. So they start as an acute side effect, and then treatment ends, but they don't go away. And that's called a persistent treatment effect. We see that in about a quarter to a third of people with fatigue who develop acute fatigue, and then it doesn't seem to go away, and they have that fatigue going on for years or even decades after their cancer treatment ends. There's also something called late treatment effects, which are new side effects that can all of a sudden just appear months or even years after treatment ends out of the blue. And we know that persistent and late treatment effects can be complicated by a number of different factors. So older age, people having different comorbidities can make these things worse, genetic risks, and then also behavioral and lifestyle factors. So not being physically active, those types of things can make these specifically the persistent treatment effects worse. But we also know that the survivorship experience is very individual. So it's very hard to predict, you know, who is going to have persistent late effects, how long they're going to last, and when people are going to be starting to feel better. So in terms of the physical side effects, you know, anybody who has had treatment, there is a risk of local or distant recurrence of their disease or second primary cancers. And I think our healthcare system does a pretty good job of providing surveillance for that. So patients come in, once they're finished their treatment, they come in every 3 months, 6 months, 12 months, and have their follow-up visits where they have their scans or tests to make sure that their cancer hasn't come back. But as I said, treatment can affect almost all of the different bodily systems and results in these long or persistent side effects. And these can include things like cardiotoxicity, so affecting your heart, lymphedema, so that's swelling that can happen in your arms, your neck, your lower limbs, bone loss, pain, fatigue, cognitive impairments, neuropathies as a result of chemotherapies. We see functional limitations and deconditioning. Some people report sleep disturbances, sexual dysfunction, bladder and bowel dysfunctions, and infertility. So these are some of the more common ones that we would see. A lot of these symptoms co-occur, which means that you'll see something called a symptom cluster, where somebody has pain and fatigue and insomnia, and the symptoms sort of perpetuate one another. So one thing when we're talking about cancer rehab and different physical side effects is that certainly there are disease-specific side effects, like in breast you may see like lymphedema, shoulders dysfunction, body image, and that's related to the treatments that people get. But then there are cross-cutting side effects that you might see across all of the different diseases. Like fatigue is something we would see across all different cancers, or pain, neuropathy, those types of things. We do know from some fairly large studies that have been conducted over the past couple of decades, comparing people who have had a cancer history and undergone cancer treatment versus those who are age-matched controls who have had no cancer history, that cancer patients or survivors who are in the gray lines here do report poorer health, more limitations of their activities of daily living or functional limitations, and have a harder time being able to work. In terms of psychosocial well-being, patients and their families also face significant psychosocial and economic consequences. Very common, we see patients that have a fear of cancer recurrence. There's some anger, anxiety, people feeling emotionally vulnerable. And there's also changes in outcomes with social relationships, like marriages and relationships with coworkers and friends, and community involvement. There are a number of practical concerns that people have to deal with. Even though we have a funded healthcare system, there are significant financial implications of going through cancer. There's difficulties for some people getting back to work, employment and insurance discrimination, And typically we find that psychosocial and also physical side effects often are undiagnosed and undertreated, despite the fact that there are treatments for these things. So this was a study that was done by the Canadian Partnership Against Cancer a couple of years ago, and it included over 10,000 cancer survivors across Canada. And they were looking at, it was quite a long survey asking about, these are people who are post-treatment, asking about common symptoms, side effects, and access to services. And what they found was that 8 out of 10 patients reported having physical challenges after their treatment ended. And fatigue, changes in sexual function, and fertility were very commonly reported symptoms. 7 out of 10 reported having emotional challenges. This included worry about cancer returning, depression, and 4 out of 10 reported having practical challenges like returning to work or difficulty getting life insurance. What's unfortunate is that a lot of people said that they didn't seek help for these concerns after they completed treatment. And these were some of the reasons why. People thought, well, I was told it was normal and I didn't think anything could be done about it, or I didn't want to bother anybody and ask, or I didn't know that the services were available to help me. Sometimes people are embarrassed to ask. So this is unfortunate. First of all, people not knowing that there were services, but also people just thinking it's normal and they have to suffer when that's not really the case. I did want to talk a little bit about this cycle of sort of poor functioning and what happens. So as people undergo cancer treatment and experience cancer-related side effects that impair their function and result in disability, this can result in poor quality of life and actually increase symptom burden. And that idea of those symptom clusters where people start experiencing more and more symptoms. So they start having fatigue, that actually causes them to become depressed, that causes insomnia, that makes their fatigue worse, those types of things. And because they're feeling terrible and not very well, they actually then start engaging in less health behaviors, things like being physically active and eating healthy and taking care of their emotional health. And at the same time, we see that this can result in increased healthcare utilization and costs. And this becomes quite a perpetuating cycle. There are ways that we can try to intervene, though, and sort of break this cycle. So certainly once we identify impaired function and disability, we can provide rehabilitation. I'm going to talk a little bit about what that is. There's also situations where we can try to predict before people get impaired or develop symptoms and disability to try to prevent those things and condition people before treatment so that they can withstand their treatment better. And I think it's really important that, I said, our healthcare system and our cancer care system, it's not different than any other in really North America, is very much focused on that acute treatment phase, like focusing on that tumor response, but not really having much of a focus on people's function and quality of life and recovery. And so we know from patients that they want a balance of both. And I think we have to really advocate for that moving forward. So back in the early 2000s, there was Institute of Medicine pivotal report that came out on cancer survivorship, and they came out with 4 recommendations in terms of things that we need to focus on to improve the care for cancer survivors. These included certainly making sure that we include surveillance for cancer spread and assessment for medical and psychosocial late effects, prevention, and so this is more secondary prevention of new cancers and recurrence. Coordination is really important. We need to be ensuring that we're coordinating care between our specialists and primary care and ensuring that all of our care is coordinated and there's good communication and coordination and people know what each other is supposed to be doing to help the patient. And the 4th bucket is intervention, and this is around developing appropriate responses to deal with the consequences of cancer and its treatment. And this is where really cancer rehab falls in. So what cancer rehab is really focusing on the prevention and treatment of those acute, persistent, or late effects of cancer and its treatment. And the focus is on maintaining health to optimize functional status and quality of life. And there's lots of different studies that have now been, published over the past couple of decades, looking at the impact of rehab interventions on a number of different outcomes like pain, fatigue, deconditioning, and they've all been shown. All of these outcomes have been shown to improve with different rehab interventions. So there's good evidence that it works. So we know that cancer rehabilitation can reduce functional limitations of cancer survivors and improve their social well-being, vocational functioning, quality of life, and their physical well-being as well. We also know from published studies that about 2/3 of patients really could benefit from cancer rehab, and a large majority of patients who have advanced disease could also benefit from cancer rehab, but only about 1 in 10, or around 10%, actually receive rehabilitation services. The reason for this is often that patients and healthcare providers are not aware of what rehab can offer to them. But in Canada, we have a further problem in that cancer care, as I said, is still viewed and funded as an acute condition, and outpatient cancer rehabilitation is not funded through our provincial health systems. So as a result, there is certainly inpatient rehab that people will get a little bit of when they're in hospital if they have to be hospitalized, but outpatient rehab for cancer is generally not funded. And so what you see is that there's this wide variety or variation in terms of services that you might see even within provinces. And where services do exist, they're generally siloed. So there might be just a service for one thing like lymphedema, but it's not sort of comprehensive rehab. So really what we try to advocate for is the fact that we know that there's an increasing number of cancer survivors, along with lots of evidence that there's lasting effects of treatments that impair people's quality of life and result in functional limitations. And so this really serves as an urgent call to action that we need to, as a healthcare system, invest in the recovery and well-being of cancer survivors to help them recover after cancer treatment. And I really like this quote from a paper by Julie Silver and Gilchrist from 2011. It's 10 years old now, but I think it's great, and it really just supports that little infographic that I showed you earlier on. The experience of entering the medical system for many cancer patients is that they feel very good at the beginning, and then the treatments make them profoundly ill and often disabled. When they are sicker and more debilitated than they have ever been, they are discharged to follow-up care, which may include things such as routine screening for cancer recurrence, managing ongoing medications, and others, but this does not generally include a multidisciplinary rehabilitation intervention. In effect, the medical system creates a situation where high-functioning individuals are given life-prolonging treatments and then left to struggle with how to recover from the toxic adverse effects of these therapies. So I'm going to switch gears here a little bit. The next 2 slides are just about the cancer rehab program that we've developed here at Princess Margaret. As I said, this is an exception to the rule, really, in North America, actually. So we have quite a comprehensive program here. It is fully funded through philanthropy, so it's not funded through our health system. And we're just very lucky here at Princess Margaret that we have a foundation that funds us for this. But I think what's great is that it provides a model for others to work towards and for us to advocate to. And a big part of our program, it's a clinical research program. So everything that we do here, we try to collect data on, learn from, so that we can use that data to advocate for services in other places as well. So the Cancer Rehab program and Survivorship program at Princess Margaret is a consultative program, which means that we don't see patients for a long time. We see them fairly quickly, maybe only 3 or 4 visits. It's risk stratified, so we try to see those patients that need us the very most, and patients that have lower needs or just need some information, we try to direct them into the community to programs like Wellspring, Gilda's Club, and some of the great programs that are available, and the CCSN website, different resources like that. We deliver care to all the different disease sites here at Princess Margaret. We actually started out in the breast site and worked with the breast site for many years, then head and neck, then the gynae site, and then over the past few years, we've opened up to all the different disease sites. And we take a very multidisciplinary approach. So you can see here in this slide all the different rehab professionals that work on our team. So we have physiatrists who are medical doctors, who are specialize in rehabilitation medicine. And we have 2 physiatrists here who have taken fellowships specifically in cancer rehabilitation. I think there are only 3 or 4 physiatrists in cancer rehab in Canada, so we're really lucky that we have 2 here. And we've developed a fellowship program here, the only one in Canada for physiatrists, and we have a new fellow coming in this year and hoping to have then a 3rd physiatrist maybe join our team after. We have physiotherapists, massage therapists for lymphedema, we have 2 dietitians, a neuropsychologist for neurocognitive changes, occupational therapists, a social worker, and then we have a team of kinesiologists who are exercise professionals that help specifically with cancer patients and getting people physically active. And these are the different types of services that we offer. So every patient that comes into our program will receive a comprehensive assessment with physiatry and occupational therapy or physiotherapy. And then based on their needs, they may be offered one of these follow-up consults or one or more. So we have lots of different things that we offer: neurocognitive, social work, return to work consult to help people when they're struggling to get back to work. When people have issues with musculoskeletal problems, they would see physiatry or physical therapy. We have a lymphedema program that includes one-on-one and group teaching. We also have a program called the CARE program, which is an 8-week structured cancer rehab program. This would be very similar to what you might see in cardiac rehab. So people come, it's a weekly program. It started out as an in-person group program here at our center called the Elixir Center at Toronto General Hospital at UHN. And so they would exercise together. There's some classes each week on learning different self-management skills by our different rehab team. We've actually developed an at-home program of this too. So it's a virtual 8-week program for patients who aren't able to come in because there's lots of barriers to coming down to the hospital once a week. And we were really lucky that we had this program in place before COVID. So once when we were affected by COVID and we couldn't have patients coming into the hospital, we already had our care at home program available, and so we could get people still receiving rehab while they were at home. We've recently developed a Care Advanced Cancer program, which I'm going to talk about in a minute when I talk about our Can Rehab grant. And we're also just launched a care for allo BMT patients. So we have specific streams. And actually this fall, we're just developing a care program for adolescent young adults. So we just have tailored groups that we run through, and it's the content of the care program is a little bit different depending on the group that we're dealing with. Oh, and I lied. There's one more slide on our program, and I just want to show that, you know, when you build these programs, what you see is a huge uptake once people start learning what you offer. So within Princess Margaret, you know, it took us some time for the doctors and nurses to learn about what we offer and what we do. But once they did, they started increasing their referrals, and patients were coming back to them saying, that was the most valuable visit I've ever had. You know, it was so helpful to me. And so hearing that from their patients made them, you know, want to refer more patients. And so what you can see is just the huge increase in the number of patients that we've seen year over year. And in 2021, we delivered over 12,000 patient visits. So it's a really, really busy program. So I'm going to switch again now. And just for the last part of my talk, I want to talk about the Can Rehab grant. Because I think it's really exciting opportunity to look at ways that we can improve access to cancer rehab across Canada. So a couple years ago, the Canadian Cancer Society and Canadian Institute for Health Research put out a call for team grants in cancer survivorship. And they were able to fund a number of teams across Canada on various topics. So we put in a grant looking at trying to improve access and access to cancer rehab. And we were very lucky in that we received the funding. So we have, I'm one of the investigators, along with Kristen Campbell, who's in Vancouver, Jonathan Greenland, who's a radiation oncologist in St. John's, Anthony Riemann, who's a medical oncologist in St. John, New Brunswick, and David Langelier, who's a physiatrist here in Toronto with our program, and he's a new investigator. We also partnered with Canadian Cancer Survivors Network and worked alongside Jackie with the development of this grant as well. So that's been a really nice partnership. And I have presented actually to this group before, so some of this might be a little bit of a repeat for you, but I can give you some update on some of the projects. So the reason why we developed this team grant was really, as you know from the background that I've already provided to you, that a lot of the adverse effects and cancer-related impairments that patients experience often go undetected and undertreated, and can really diminish people's ability to participate in their life roles. And so over the past 2 decades, there's been these calls for increased attention to the management of adverse effects. But I think what's really important is that we need to have the evidence base to show that these interventions work and that we can get people, that people want these things. And so that's really the focus of this grant. The other thing that was important to us is that there's a growing number of people, as I mentioned earlier on, who are living for years with advanced metastatic disease or intermittent disease, who traditionally have been excluded from cancer rehab type and survivorship services, but could really benefit from them. And so we wanted to focus on that population as well. So the team goals are, it's called the Canadian Cancer Rehabilitation Team, so Can Rehab. It brings together a really large group of researchers, clinicians, cancer survivors. So we, I think, had over 50 people on our application. And we're running this, the team grant, the studies at 4 different cancer centers across Canada. So at BC Cancer, Ontario, Princess Margaret in New Brunswick, and in Newfoundland. And with this grant, we're going to be conducting 3 projects that are focusing on improving the systematic identification, so being able to identify adverse effects of cancer and its treatment, increasing access to cancer rehab using innovative e-health solutions, and extending reach to those people who have incurable or metastatic cancer. The projects, we had to sort of pick disease sites. We couldn't include everybody for this grant, so we've included breast, colorectal, head and neck, and lymphoma cancers. But I don't think that what we learned from this can't be, expanded to other cancers moving forward. It's just, given the funding envelope, this is sort of what we had to do. So we have the 4 centers, the 4 disease sites. The first project is developing, and I'll go into a bit more detail of each of these projects in a minute. So the first project is the developing what's called an electronic prospective surveillance model for cancer rehabilitation. So basically, we're developing and evaluating an online system that will screen patients for cancer-related impairments and then direct them to cancer rehabilitation services. The second project, we've developed, as I mentioned, we have our CARE program here. We've developed our 8-week online cancer rehab program called Care at Home. And we're going to be implementing that program at the 4 centers involved in this grant, and running a randomized control trial to look at the effectiveness of it. The third project is looking at our CARE Advanced Cancer Group. So this is another 8-week program for patients specifically that have advanced cancer. And we're running a phase 2 randomized control trial to look at the impact of that program. And that's run in Toronto and Vancouver. So the first project, the identification of rehab needs, is called REACH. And REACH is really a prospective surveillance model, which is a model that's been proposed to routinely assess patients' needs and functioning at different intervals to be able to identify things early on. So the rationale for using a prospective surveillance model is that we have an increasing number of cancer survivors who can expect a relatively normal life expectancy, and failure to treat these persistent cancer-related side effects can adversely affect their well-being and functioning for decades. Treatment-related side effects and impairments are common and often go unreported and unrecognized. Many treatment-related impairments can either be prevented or they can be treated through education, self-management, or comprehensive rehabilitation. So we have ways to address these things, but we know that few people receive such care. So that's the rationale for why we need to develop these types of systems. So implementing systematic screening, though, the idea of implementing systematic screening within our cancer centers, it has been proposed as one solution, but there are a lot of challenges with implementing screening systems within our oncology clinics. If any of you here are patients or have been patients at Princess Margaret, you'll know that the clinics are very busy, and patients in Ontario actually are routinely asked to fill out their ESAS, which is a symptom screening tool, when they come to their visits. But often, you know, because the clinics are so busy and the oncologists and nurses are so busy, nobody really looks at those scores or does anything with them. And part of that is just, you know, they're very busy, but also they don't necessarily know what services are available. Maybe if they ask, they're opening up a can of worms. So unfortunately, just adding in questions in clinic doesn't always result in any solutions for patients. So to address this, we have to make sure that when we build these types of models, that there are very clear pathways to appropriate resources and interventions where we can actually direct people to. And the process should be personalized and tailored responses. So we don't want to just be keep asking people the same questions, or questions about things that aren't applicable to them. So asking somebody about return to work questions when they're retired would just be annoying to somebody. Asking people more and more questions about fatigue when they don't have fatigue would also not be appropriate. So we need to have systems that can sort of tailor the questions and can be smart systems to adjust based on patients' responses. So there's, I think, great opportunity when we think about technology, because it can provide very cost-effective and patient-centered, tailored, and even AI informed models for implementation of prospective surveillance models. And it can enable this idea of remote monitoring of cancer survivors and the development of automated and personalized link to treatment responses. But these have not yet been developed or implemented, and that's really what we're trying to do with this first project. So what we've done is we are developing and implementing an electronic prospective surveillance model for cancer rehab, and our system is called REACH. This is a web-based application. You could access it either on your phone, on an iPad, on your computer. Patients would register into it from one of the 4 centers across Canada that are involved in the Can Rehab grant. And then based on where they are in their treatment, they'll be prompted at certain time intervals to check in and answer their questions. The questions are really, really short, depending on the disease site, site that they're in. It'll be different questions. It's generally screening for 5 different physical impairments. And then based on their responses, there's a risk stratified automated system that would direct them either to patient education resources, community-based programs, or will trigger for them to see their doctor and print out a referral form that has information for the doctor on what to do. So I'm really happy that this system, we've been working over the past 2 years to develop this REACH program, and it's almost ready to launch. We'll be launching it in the fall across our 4 centers. We've included a number of different focus groups, interviews, feedback from patients and end users to get feedback on the usability and what people would want in the system. And so I think it's looking really great, and I hope that in a couple of years we'll be piloting it for 18 months and implementing in the systems and piloting it, and then over 18 months working with engineers as well as our research team here to improve the system each quarter. So we'll be going every 3 months. We'll be updating the system to improve it based on what we're learning from how people are using it. So I hope that I can come back and present on this, once we launch it and start gathering that data. The second project is our Care at Home intervention, which is our 8-week at-home cancer rehab program. So in terms of the rationale for why we wanted to do this, right now the evidence on cancer rehab, which shows that it is effective, comes largely from trials that have done face-to-face delivery in clinical settings. And that's how actually our care program started. It was face-to-face, group-based in the hospital. But we know that cancer survivors face very significant barriers to access these types of services, whether it be that, you know, they live far away, they have childcare issues, they're working, or even just being too fatigued or having poor health can make it hard for people to come to medical facilities for these types of programs. So the use of e-health interventions that use technology where we can deliver care at patients' home has been one way to reduce these barriers and be able to still provide rehab. And this approach has actually been established in other chronic diseases like heart disease and diabetes, where they do have these types of programs. So this is really, you know, and also actually in cancer, e-health technology has shown promise with physical activity interventions and psychosocial interventions, and some interventions like targeting specific symptoms like fatigue or insomnia, but nothing like in terms of a actual comprehensive rehabilitation programming. So our second project is taking our Care at Home program, which, as I said, is an 8-week program, 8-week virtual program, and implementing it in the 4 centers across our CAN Rehab team, and testing its effectiveness and understanding also what factors affect implementation. What's really great about this is that for centers that want to adopt this program, they don't necessarily have to have infrastructure like a gym and things like that. They just need to know how to deliver it so they can offer it to patients at home. So that's why we're really focusing on the implementation piece too, so that once we're done this study, we'll have like a toolbox. So if a center comes to us and says, oh, we want to use this Care at Home program, we want to offer this at our center, we can tell them, okay, this is what you need, this is the training program, this is how much it's going to cost you to deliver, these are the health professionals that you need, and really provides them with an outline of how they can actually implement it in their center. The Care at Home program is really great because you know, it's not just sending people home and saying like, here's your rehab program, go home. There's lots and lots of support for people. So they have weekly e-modules that are interactive modules that they can get all their learning from. They do see their kinesiologist in person to get a fitness assessment, and then the assessment is tailors their exercise prescription. So they will get a tailored, personalized exercise prescription that gets entered into an app called PhysiTrack, which the patients then will download onto their phones or their computers. They can go in and they can see their exercise prescription in that system. And every exercise that has been prescribed to them has a linked video, so they can watch the video. Even though the kinesiologist will show them how to do the exercises and things like that, it's hard because sometimes you get home and you think, oh, I forget, like, how was I supposed to do that one thing with my arm or whatever? So you can watch the video and do it along with the video, and it tracks whether you've done it or not. The other fun thing that we have in this program is that all of our participants get a Fitbit. So while they're in the program, they're wearing a Fitbit, and it helps us to track their activity and their sleep. But it also, people love this, and they find it really motivating for getting physically active and trying to get in all their steps they need every day. Once a week, we also have our kinesiologist they have a booked oh, my light just went off, sorry. They have a booked appointment with patient. So there's a video check-in where the kinesiologist will meet just for about 15 or 20 minutes on video with the patient, checking in. How's your week going? Did you look at your e-modules? Do you have any questions? The kinesiologist can see the Fitbit data, so they can say, oh, I see like yesterday you didn't have a great day, or talk about barriers, help to coach them in their behavior change. So there's lots of support. Even though people are at home, they're getting all that personalized support. And we're seeing really, from the pilot data that we published, we saw really impressive increases in improvements in disability, increases in functional capacity. So that was really encouraging. And this trial, I think, will really help to provide some more evidence for that. And then the final project is our Care Advanced Cancer group. So I talked about this before, but we know that there are more people now living with a metastatic disease for years and decades. But we know that often, even though patients are living for a long time and with advanced cancer, they're still undergoing lots of treatments. The cancer itself also can lead to loss of physical function, and so they're struggling with many different side effects from those treatments. And improving this loss of function and independence and addressing the high symptom burden is described by people who have metastatic cancer as one of their highest medical priorities. But as I said, very, very few actually receive any kind of comprehensive cancer rehab. Even though we know that they can address common impairments and reduce the rate of functional decline in patients with advanced cancer. So the focus of rehab in patients with advanced cancer is not necessarily recovery, but maintenance of quality of life and function for as long as possible. And so there have been urgent calls for the development and evaluation of very proactive, multidimensional interventions that can address the needs of this growing population of cancer survivors who can continue to live for many years with their disease and impairments, and that we can help. So Project 3 is testing the feasibility of a group-based cancer rehab program focused on maximizing potential for independent function and quality of life for those who are living with incurable, locally advanced or metastatic solid tumor cancer. And we're offering this program both in-person group or virtual group. And so that's called a preference-based trial. And this will be run at Vancouver and Toronto. And this project is going to be launched in November. We're just pilot testing it and doing the training right now. And then this project will be launched in November. So I'm really looking forward to this trial happening as well. I think it's really important. I just want to finish by talking about the role of patients and families on our Can Rehab grant, team grant. So first of all, in the development of the grant, there was lots of input. And as I said, Jackie was a big part of that. But since then, we've developed a patient and family advisory committee. We have 14 people on our advisory committee from across the country, representing caregivers and patients from a diverse diagnoses and different stages of where some people are in treatment, some people have advanced disease, some people are post-treatment. So it's a really, really amazing group. The role of our advisory committee is to play an advisory role as an overarching committee and ensure that the cancer survivor perspective remains at the forefront of all of our work and influencing the direction of the research and our implementation activities. So we have quarterly meetings with our committee. We'll often circulate materials between those meetings where we ask for people's input and advice on things. And really, you know, having this really helps us to build a very sustainable, accessible, and equitable cancer care system. And I think more and more, you know, people are including patients and families on their research teams, and I can tell you how valuable it is. It's been so meaningful for me as a researcher to have this committee. Everybody's really engaged, and you know, the things that they bring up are things that I maybe never would have thought of and are so important. So I'm going to finish there, but I'm happy to answer any questions that you may have. I think we have a bit of time. Yeah, we have about 10 minutes, so that's great. I don't know if there's the chat. Can't see anything in the chat. I don't know if Connie's still there. I think Connie might be having some problems with her computer. So, oh yeah, here we go. Yeah, she is. She's having problems. I don't know if people are able to put in their questions in the chat. If you want to do that, I can see the chat actually, so I could read them off. If you have any questions or comments, I'm happy to answer them. If Connie was going to read them out, but I think I can see them if you want to write in the chat. I think you can just type a message in the chat box. Or Connie, if you have any questions, you can put them in too. I don't see anything coming up. I guess, you know, we do have a couple more minutes. I just really want to reinforce this message that I know Canadian Cancer Survivors Network is a really important advocacy group, and I've participated in a few events with CCSN and at Queen's Park and advocating for funding for cancer rehab. But you know, and I think that that's really important, and I think that the more and more that people start to demand these services and ask for these services, you know, the more people will wake up and understand that it's important. This is actually how palliative care became more, you know, supported and got where it was able to get more services provided, is really the advocacy of patients themselves saying, this is important, we need this. And I think that we need to have that advocacy. So working with Canadian Cancer Survivors Network to advocate for this is really, really important. And my role, I'm certainly happy to advocate, but also I want to bring the research to the table as well, to show that these programs actually do have an impact. They improve people's quality of life and function, but they also can reduce healthcare costs as well. Less people are coming into the hospital when we're dealing with these up front. I have, so there's one comment. As a cancer survivor, I did not, one second. As a cancer survivor, I did not have any cancer rehab made available, and as a result, I believe I've had negative side effects. I am now a patient advisor and would love to find out more about Princess Margaret's service. Okay, that's wonderful. And you have my email. It's on my last slide there. Feel free to please reach out to me. I'm happy to tell you a bit more about it. And you're right, most people in Canada actually don't have any access to cancer rehab. We're very lucky at Princess Margaret because of our foundation, but it shouldn't have to be this way, that just because you're at Princess Margaret, you get access. It should be something that people can access everywhere. Somebody else said, I'm glad to see head and neck as part of the project study. I fall into that group. Okay, yes, I mean, we did try to pick groups like head and neck where there is a really high rehab need, and there are actually services that we can provide to help people. So yeah, head and neck is a great group to work with. Are the remote locations patients being considered for these projects? Definitely. I mean, for the they're going to find out about the projects when they're at the cancer center. So if they're coming to Princess Margaret or St. John's or BC Cancer, they would find out. If, you know, we actually have lots of patients at Princess Margaret that come to Princess Margaret but live very, very far away. And so they can still be part of the projects. For the purpose of the research, they kind of have to come to the centers first to find out about the projects. But the idea is really that, you know, if we find that these are effective and can be implemented, that they could be offered. Certainly, like the Care at Home program is a great option for people who live in remote areas to be able to access cancer rehab. So we want to show that it's effective, and then it's something that other places could adopt to help support patients who are far away. Are you looking to roll this out across Canada after the project is done, including the app? We are hoping that we can do this. You know, that's why a big part of what we're doing in all three studies is looking at the implementation piece. You know, a lot of times with research, you do research and then you find the results and then it goes into a journal and it goes up on a shelf and nobody does anything to follow up with it. The focus of these is really, and the funding call, the call for funding through Canadian Cancer Society really wanted people to focus on the implementation piece. So how can we ensure that these are sustained after the funding ends? So yeah, we are looking to definitely keep, especially Project One, the Reach app, we're implementing it as part of standard of care. The idea is once the funding's over, it will still be there. Project Two, if we can show that it's an effective intervention, I would hope that other centers would want to adopt it. And like I said, we will be building that nice toolkit to help people with doing that. I think that was Okay. Can patients from other areas participate in the Care at Home program? Right now, for the purpose of the research, we are just including those 4 centers for Care at Home. But, you know, I think the trial is actually going to go pretty quickly. We are hoping to launch the trial in the new year, in the beginning of January. I expect that we'll be able to recruit and complete the study, you know, within 18 months. And you know, the goal will be to get the results out as soon as possible, and really work on trying to get some uptake of the intervention. Okay, next question. How is Care at Home integrating or fitting with the Excel and ACE programs from the University of Calgary? Great question. So the Excel ACE program is another one of the team grants, actually, that is an exercise program that Nicole Coulis-Reed is leading out of Calgary. So what we're trying to do is, as much as possible, link patients to programs within their community. So, for example, if Excel is happening, like I know with BC Cancer, there's some Excel programming happening. So patients who are at BC Cancer would be then, when they need exercise programming, they would be directed through the app to that system. So as much as possible, we are linking to those types of programs, including Excel. I would also just comment that if any of you are interested in you know, contributing or getting involved with the research team, please reach out to me. You know, the more the merrier is the way I look at it. We always have room on our advisory committee, or if there's a specific project that you want to get involved with, please just reach out to me, send me an email, and we'll see how we can get you involved. Next question. Oh, another question. Hi, how do you see tying in the GPs who have to take on aftercare after care of cancer survivors? That's a really good question. For project 1, when we're identifying patients that have very high levels of impairment, like high pain, high fatigue, unresolving symptoms after we provide other resources to them, we're asking them to print out a referral form and go see their family doctor or their oncologist. On the referral form, it says, you know, please give this to your family doctor. The referral form provides information to the family doctor or the oncologist, whoever the patient wants to go see, on the guidelines. What should they do? What are the resources they can refer to? That type of stuff. So it helps to provide that information that, you know, family doctors and oncologists often don't have. They often don't know where to refer or what to do with these things, and so it provides some really nice guidance in terms of what should they do. I think somebody's unmuted now. Not sure. I can hear some feedback, but anyway. Oh, we're out of time. Okay, so it's 2 o'clock. I want to thank you all for joining me today. I hope you found that helpful, a helpful hour of your time. And as I said, feel free to follow up with me if you have further questions or are interested in getting involved, and are interested in, you know, advocacy anytime. I'm happy to come help present in other forums. So just let me know. Thanks so much for this opportunity, Connie. I really appreciate it.